So hello everyone and welcome to this advanced coding webinar. And welcome back if you attended the MedDRA Coding Basics webinar at the end of April as well. Nice to meet you all to go through some additional, more advanced examples and aspects, more exercises on how to perform MedDRA coding. I'm Caroline Wilson and work as a medical officer at the MSSO and will be your instructor today. And I'm supported by my colleague Leander Molt, who was speaking to you before. So together we will take you through this webinar, which will last for about 2 hours. We would like to make this webinar interactive. Leander mentioned this already, so please submit your questions or send us your comments through the question panel, and I will allow as much time as possible for questions both during the course and also at the end of the presentation. But please do not raise specific coding questions, as we can't help you with individual verbatim terms. But we can guide you, of course, and this is the intention of this webinar, in terms of coding principles. Now let's start with some general slides. Most of you will know that ICH adopted the development of MedDRA in the mid of the 1990s and became the owner of the terminology. ICH then, on contract, appointed the MSSO to take care of the maintenance and further development of the terminology based on user feedback, to provide and organize corresponding training as the one that we have today, and to administer the MedDRA licenses. And all these MSSO activities are overseen by the ICH MedDRA Management Committee. ICH is not only the owner of MedDRA, but also owns today's training material. It is protected worldwide. You may use the slides with the exception of the MedDRA and ICH logos, but will have to clearly indicate that ICH owns the copyright. Also, any adaptations of the slides have to be clearly labeled. The second bullet point refers to warranty and liability issues you should be aware of, and the third one is not relevant for today because we will not be using any third-party slides. These are the topics that we will cover today. We will first discuss some more advanced principles that are outlined in the Points to Consider document for MedDRA term selection, which is the coding guidance document provided by ICH. We will then look into the MedDRA concept descriptions and at several advanced coding scenarios. And we will use Poll Everywhere. This is an application for our polling and the MedDRA browser as well to apply some of these advanced concepts from the MedDRA term selection Points to Consider document. And finally, we will go through some tips for coding, what we call the coding pearls, to help you with your coding tasks. And we will conclude with a Q&A session. But as mentioned earlier, you will be able to raise questions throughout the session as well. But again, please understand that it is not in the scope of this training to help you with very specific verbatims that you came across, but rather address the advanced coding principles and related coding scenarios on a more general level. Now let's start. The next 2 slides explain about the polling. If you would like to join the quizzes and participate in the examples today, there are 2 ways to do so. The easiest way is to scan this QR code with your smartphone or tablet. This will bring you directly to the poll. Or you may enter the indicated web address pollf.com into the URL bar at the top of your internet browser in your computer, tablet, or cell phone. It will then take you to a log-on screen and you'll be asked for a username. The poll is completely anonymous, so you don't need to enter your name, but please enter my name, my new username, Carol N. Wills 584 with no spaces. Nothing more to be entered, just click join then. And Leander has put these credentials in the chat as well. Please don't get under time pressure because you will be able to see these credentials on each slide that relates to the quizzes, and I can also show the QR code in between if you need it. Now let's see whether the polling tool works. Where are you joining from today? So I see Russia, I see Kenya, welcome. I see Indonesia, India, Spain, buenos días, South Africa, Portugal, Italy, buongiorno, kalimera, merhaba to Turkey, Greenland. Somebody's sitting in US. You must be an early bird. It's very early there. So I also see China, Niao, Antarctica. I don't believe that. So it disappeared. So welcome everyone. I'm sitting in Berlin in Germany, and I'm very happy to welcome you all. So the poll seems to work. Now please let me know whether you have already attended the Coding Basics webinar. I see that many of you did so already, or you are very experienced MedDRA coder. But for all others, it is really helpful to attend the Coding Basics webinar as well, because it will provide you with important information about the MedDRA structure and some basic principles that should be applied in operational coding from the ICH coding guidance document. Our webinar today builds on it, and I will not be able to go into the details of what we have covered in the Coding Basics webinar. So please make sure to also attend the MedDRA Coding Basics webinar, because I believe it will be useful for you if you are a newcomer to MedDRA. Now let us start with our topic today and first look at the MedDRA term selection points to consider document that provides guidance for operational coding. This is a screenshot of the cover page of the current ICH PTC document for MedDRA term selection for version 28.0, so the current version. It provides guidance and many examples on how to perform accurate and consistent term selection using MedDRA. This guidance should be the basis for your coding decisions and intends to promote overall coding consistency and to facilitate common understanding when sharing clinical data. So MedDRA allows us to speak with one language when sharing medicinal product safety information between different biopharmaceutical companies, between pharma and CROs, or when talking to regulators. This document was developed and is further maintained by an international expert working group appointed by the ICH Management Committee I mentioned before, with members from regulators and industry of the ICH regions, the MSSO and the Japanese Maintenance Organization or JMO, and the WHO as an observer. There is one original and comprehensive version that is available in English, Japanese, Chinese, Korean, Spanish, and Russian. It is updated with each major MedDRA version release, that means beginning of March each year. In addition, there are condensed versions of this original document in other MedDRA languages, except those, of course, that I have just mentioned before. And you see these languages listed on the slide: Arabic, Brazilian Portuguese, Czech, Dutch, French, German, Hungarian, Italian, Portuguese. So these condensed versions focus on the general coding principles without going into further details for selected topics. They are not updated with each MedDRA version release, but on an as-needed basis. The Coding Basics webinar I've mentioned before, it focuses on the basic principles for term selections that are outlined in the first part of the Points to Consider document. Today, we will focus on specific coding topics, more advanced ones, that are addressed in the second part of the Points to Consider document for MedDRA term selection. And you see the list of these topics here, like diagnosis and provisional diagnosis with or without signs and symptoms, death and other patient outcomes, combination terms, congenital terms, neoplasms, investigations, and the list continues on the next slides. And all the ones that are highlighted in yellow, we will either address based on information from the MedDRA points to consider document or via exercises that we will take today or address today. As you see topics like medication errors, overdose, toxicity, poisoning, drug interactions, indication for product use, off-label use, product quality issues, etc. Let's first start with some important general principles which are addressed in the points to consider guidance. We have already discussed them in more detail in the Coding Basics course. Coding is done on LLT level, the data entry level, and only current LLTs must be used in ongoing coding. The LLT selected should capture as much information provided by the original verbatim as possible. So code as reported. Capture as much information as you can when doing MedDRA coding. When doing so, we should not add or also not subtract relevant medical information. So basic coding rule, code as reported. So this can be seen in this example. Reported is an abscess on the face. This verbatim should not be coded to just abscess, because it is medically relevant to also capture the manifestation site that was reported, because an abscess could also occur at different anatomical locations. That is why we would select LLT facial abscess to capture as much information from the report as we can. And always remember to select current LLTs only. The non-current LLTs are still in the terminology for historical purposes to support interpretation of legacy data and legacy data conversion, but they should not be used for ongoing coding. Important really to remember. In some instances, you may consider to select more than one MedDRA term to capture the full information of the verbatim. Let's look at the example on this slide. If you are to code the verbatim metastatic gingival cancer, you may decide to select either gingival cancer or LLT metastatic carcinoma to not duplicate the event. But selection of only one term may lead to loss of specificity, of course. And you would need rules for the prioritization of the information received to ensure coding consistency. But you may also decide to capture the full information and split code by assigning LLT gingival cancer and LLT metastatic carcinoma. When taking this approach, you would duplicate the event that is the malignant neoplasm information. In the end, you are free to choose either option, what we call lumping or splitting. But make sure to document your rules and to use them consistently. Now let us look at another example an example for this principle. How would you code left foot and ankle swelling? Would you split this reported event and code to swelling of feet and ankle swelling, or would you lump this information under one of the other LLTs? How would you approach this verbatim? Peripheral swelling, swelling of feet and ankle swelling is another option, unilateral leg swelling, or local swelling, because left foot and ankle are localized, very near, so it's a local swelling. I see many of you are voting already. So what would be your coding approach here? me look what you're going for. So most of you take the correct approach. Swelling of feet and ankle swelling is the correct code assignment here. So let me close the poll and show you why swelling of feet and ankle swelling, so split coding is appropriate here. If you look into MedDRA, you see that ankle swelling is considered a joint swelling. The ankle is a joint, whereas the swelling of the feet is grouped under PT peripheral swelling. So, meaning that we have two different medical concepts in our verbatim, and these have to be coded separately. And this example also nicely shows why checking of the hierarchy when doing coding is really useful. So it's often, really helpful to check the hierarchy before making any definite coding decisions. Next one. How to code pain in hand, severe pain in leg and toe. Would you just code to pain or to musculoskeletal pain? Would you split code and code to pain in hand and pain in leg and pain in toe? Would you just code to pain in extremity and lump this together? Or would you code to pain in hand and pain in leg because the toe is part of the leg? What would you do with this one? Split code or lump together? What would you do? Most of you would split code in this instance. Many also, second option, most preferred option is pain in extremity or pain in hand, pain in leg. So let me close the poll again and show you the correct answer. So here it would be correct to lump this information together under LLT and PT, pain in extremity. Why? Again, it's really helpful to look into the hierarchy here. You see that pain in toe, pain in leg, and pain in hand are all grouped under the PT, pain in extremity. So in such situation, you would select the LLT that is identical to the PT name. And again, you can see that checking the hierarchy is really important. So whenever you have such a scenario where you have a verbatim that relates to several LLTs that are linked to the same PT, we are advised to just select the LLT that is identical to the PT name. As indicated before when showing these examples for splitting, checking the hierarchy is an important general principle for term selection. Before making a coding decision in more complex cases, it is advisable to check the MedDRA hierarchy to reassure yourself that you are on the right track, that the selected LLT is medically correctly represented in the MedDRA hierarchy. As an example, a non-infectious condition should not be represented in SOC infections, or a condition which was acquired later in life should not be coded to a term in SOC congenital. This slide now provides an example for checking the hierarchy. Another scenario. If you are to code the verbatim feeling completely drained, you won't find an exact match in MedDRA. You may then consider to assign LLT worn out, but may be unsure whether this is appropriate. But when checking the corresponding PT, and it's PT fatigue, and the LLT siblings underneath, like for instance LLT exhaustion or LLT tiredness, you will feel much more comfortable with your coding decisions. When not checking the hierarchy, you may even end up with a completely incorrect code assignment. If a patient, for instance, suffers a ventricle rupture due to a pre-existing hydrocephalus, the assigned MedDRA term should of course reside under SOC nervous system disorders. The correct term would be LLT cerebral ventricular rupture, and same PT, and you see it resides in SOC nervous system disorders. When searching for ventricle rupture only and not checking the hierarchy, one may assign the LLT ventricle rupture. It seems to be a perfect match, but this LLT and PT is grouped under HLT myocardial disorders, NEC, and resides in SOC cardiac disorders. And this is actually a real-life example that I came across when doing spot checks of code assignments when working in pharma. So it's really helpful to check the hierarchy when coding more complex verbatims. Another topic that I would like to highlight today are the concept descriptions. These are descriptions on how a medical concept is interpreted, used, and classified within MedDRA. They do not represent medical definitions as you find in medical dictionaries, for instance, but they may be helpful for you when searching for suitable LLTs. The purpose of the concept description is to support accurate and consistent use of MedDRA in coding and in data retrieval, and they intend to help to overcome some differences in the use of medical terms worldwide. So you will find the concept descriptions in Appendix B of the MedDRA Introductory Guide, but you can also access them in the MedDRA MSSO browsers. So let me shortly show you how to do that. Here is the browser, and today I'm using the new web-based browser. You see it has a different user interface. It is really focusing on searching the terminology and coding tasks. You have a much better view for your searches. And if I click, I will not go into the details. All the functionalities that you may be used to based on the legacy web-based browsers are here, incorporated in the new web-based browser as well. But as I said, the interface looks different, and you can adapt the interfaces based on your own preferences. Yeah. So here we are. If I click on this little icon here, you see if I hover over it, you see MedDRA concept descriptions, and here they are. So you can see that they are grouped in alphabetical order. You find MedDRA concept descriptions for abuse, addiction, for instance, what is an acute disorder or chronic one. You see cancer carcinoma, that in the context of MedDRA, carcinoma and cancer are considered as synonyms. So carcinoma terms are generally grouped under cancer terms. Like here, an example, skin carcinoma is linked to PT skin cancer. Here's the definition of chronic, and there are also many examples that relate to product quality issues, crystal formation, for instance, coring. So terms that you may not be too familiar with. It's always helpful to look into the concept descriptions to get more information. You won't find concept descriptions for all MedDRA terms, of course, that are contained in MedDRA, but many of them are can be found in this listing here. Dose, a quantity to be administered at one time, such as a specified amount of medication. Dosage, the determination and regulation of the size, frequency, and number of doses, so a much broader term that includes the dose, the schedule, and the duration of treatment, what a dose omission is, etc., etc. So it's always useful to look into these concept descriptions, just to make you aware. Let me switch back to my presentation. Here is again the screenshot of what you just saw. And we will now address some of the specific advanced principles addressed in the PTC term selection guidance document that I've demonstrated the headers of these sections before when starting our webinar. The first advanced principle in the document is the coding of a confirmed or provisional diagnosis with or without signs and symptoms. Well, if we have, like here in this example, a single diagnosis without signs and symptoms, which is confirmed, we will only code this diagnosis because this is the only information that we have. If a provisional diagnosis is reported without signs and symptoms, we would take this suspect diagnosis as if it was confirmed and coded accordingly. In parallel, of course, we would ask the reporter for more information, whether it was meanwhile confirmed or whether another diagnosis was came out of clinical investigations and procedures. And the same approach would be taken if you have multiple confirmed or provisional diagnoses without reported signs and symptoms. Now, we have a different coding scenario here where either a confirmed or a provisional diagnosis is reported with signs and symptoms. So for such coding scenarios, the PTC document provides a preferred and an alternative solution. This is now the preferred approach. If you have a single diagnosis with signs and symptoms, the preferred approach is to code the diagnosis only. So if you have an anaphylactic reaction with rash, dyspnea, hypotension, and laryngospasm, you would just select a term for the given diagnosis that is anaphylactic reaction, because all these signs and symptoms are characteristic for this diagnosis. But if a case is reported with signs and symptoms for a suspect diagnosis, all signs and symptoms and the provisional diagnosis are to be coded. In case signs and symptoms are reported with several suspected diagnoses, all signs and symptoms and all provisional diagnoses are to be coded. Really important to remember, because these are coding scenarios that you come across quite often. So alternative, I said that there is a preferred option that I've just shown, and then there is another alternative option, and this option is to code, if you have a single diagnosis with signs and symptoms, for a definite diagnosis. So a definite diagnosis, you may code the diagnosis and the signs and symptoms. So if you have the same example as we saw before, you would code not only the diagnosis, anaphylactic reaction, but also all the provided signs and symptoms. The alternative approach for a single provisional diagnosis with signs and symptoms, so provisional diagnosis, there you would code all signs and symptoms only, because the provisional diagnosis may change. So again, same example, possible myocardial infarction with chest pain, dyspnea, diaphoresis. Here you would just select terms for the given signs and symptoms, chest pain, dyspnea, and diaphoresis, because this provisional diagnosis may change. So be aware that both options, the preferred one and the alternative option, can be selected, but the approach chosen for your organization has to be applied consistently and needs to be documented in your in-house coding conventions as well. Be aware that taking the preferred option is simpler, would lead to a leaner database, to less noise in your database, but when taking the alternative approach, you would be on the safe side, not omitting reported information, and on the other hand, data retrieval and analysis may be more complex. So it's really a difficult decision how to approach such coding scenarios, but you have both options. One cautionary remark when taking the preferred approach. The PTC document clearly states that signs and symptoms that are not associated with certain diagnosis, so with a confirmed diagnosis, that are not typical for the diagnosis, will always have to be extracted and coded separately. And I really have to say that even with a sound medical background, this is sometimes hard to decide, because clinical signs and symptoms are often not pathognomonic, meaning that they do not point at only one diagnosis, but could relate to many. The example that we have in the points to consider document is really easy. Myocardial infarction, chest pain, dyspnea, and diaphoresis, ECG changes, and jaundice. So it's quite obvious that jaundice is not a typical sign and symptom for a myocardial infarction. So you would have to code the jaundice separately. But in other instances, it may really be difficult to decide whether a given clinical sign or symptom is typical for a given diagnosis, yes or no. Let's have a look at another example. If you had a report about sepsis leading to shock from possible spontaneous bacterial peritonitis or bowel perforation, what would you do with this one? So we have two suspect diagnoses: spontaneous bacterial peritonitis or bowel perforation, and we have a clinical symptom, a sepsis leading to shock. So we would need to split code. It's a lot of information that we have in the verbatim, but what would you select? Sepsis, shock, septic shock, spontaneous bacterial peritonitis, or bowel perforation? What would you do? Yes, most of you are going for septic shock, spontaneous bacterial peritonitis, and bowel perforation. Others would prefer to assign sepsis and shock. So let me close the poll here. So we have to capture both provisional diagnoses. Perfectly right. So we have to capture the spontaneous bacterial peritonitis and the bowel perforation. So we have two separate suspect diagnoses. And for the provisional diagnosis, you just heard the preferred option provided by the PTC document asks us to code the associated symptoms in addition. And here we have split opinions. Some of you would split into sepsis and shock, but the majority prefers to code to septic shock, and this is a perfect combination term that combines both information. So we can assign this combination term that captures both the reported sepsis and the shock condition. So here we are. We have the two provisional diagnoses and the related symptoms, and we would assign septic shock, spontaneous bacterial peritonitis, and bowel perforation. Some of you would prefer to code the sepsis and the septic shock separately. Of course, you are not. Your approach would not be incorrect, because if these events occur with a clear time difference, you would document these events separately. But then you have to make sure that you first have the sepsis and that you then have the septic shock, not just shock, but you have to include the information that this shock was due to the sepsis, and that's why a septic shock would be the correct assignment. Another frequent problem area is the reporting of conflicting or ambiguous information. Oh, first let me stop here and ask Leander if we have any questions so far.
Yeah, we have a question, Caroline, but I'm not sure if you want to take it now. It's in oncology-related clinical trial, do you have any experience if primary diagnosis terms must be coded or not?
I don't know what is meant by primary diagnosis terms. Maybe the attendee can specify further what is meant by that.
Okay, that's it. Thanks,
Yep.
Caroline.
So here we have the next problem area, and this is the reporting of conflicting or ambiguous information. And the slide provides two examples from the PTC document. If no clarification can be obtained, you will have to find an adequate coding solution for such verbatims. In the first example, the diagnosis hyperkalemia does not match the lab result that rather indicates hypokalemia. The recommended coding approach for such terms is to code to the respective abnormal MedDRA ILTs. Coding then covers the fact that the lab result is not normal, but doesn't make any assumptions whether it is below or above the normal range. And just as a note, coders are frequently confronted with numerical values for lab values that need classification, and it is really advisable to add one or two references like the Oxford or Harrison's textbook of medicine to the coding conventions that are to be used as a standard, as a reference, in order to classify such lab values. A different scenario is shown in the second example, where we see an ambiguous abbreviation that could indicate either genitourinary pain or gastric ulcer pain. So this is an ambiguous abbreviation. If we cannot obtain clarification from the reporter, the best solution is to code to the underlying basic medical concept, and that is pain. If confronted with abbreviation, you always have to check some references like dictionaries for medical abbreviations in order to find out whether on an international basis, this abbreviation will always mean the same thing, meaning that it is not ambiguous. MedDRA contains abbreviations, yes, but only if they are non-ambiguous. Especially when receiving consumer reports in pharmacovigilance, vague information may be reported and there may be no chance for further clarification. Turned green is a nice example. Could relate to the skin or tongue of the patient, but also to a drug like a capsule or cream that has changed color. So we do not even know if this is something that affects the patient here. That is why we would code similar verbatims to LLT unavailable event. If we knew that it is something wrong with the patient, as shown in the second example, we would choose LLT ill-defined disorder. MedDRA includes several LLTs and PTs in SOC General that can be used for such vague coding scenarios where we know that the patient is affected, but we do not know the actual condition that affects the patient. There are other terms that you can also choose from depending on the report, like PT general symptom or PT local reaction, but usually we assign ill-defined disorder. So from what you've just heard, how would you approach this verbatim? Patient had an MI. Would you go to myocardial infarction, to ill-defined disorder? Would you go to MI or unavailable event? What would you do? What would be your preference here? Had MI. Is this a clear abbreviation? Is it an ambiguous abbreviation? What do you think? Let's see what you're going for. Oh, we have really a split of opinions here. So ME would be the closest to the wording. But there's something about this term. It is an abbreviation, and we would really make to be sure it's unambiguous. Does it always mean myocardial infarction, or could it mean something else? So we would need to look up this up in an abbreviation book or other medical reference books. So let me close the poll. So let me switch to the browser and just enter MI and search. So that's a bottom-up search now. Oops, takes a while because you see that we find more than 3,000 LLTs that of course contain MI in the wording, but we have a direct hit as well, MI, here it is. And it has a red square around it, LLT, red lettering. This indicates a non-current term. So it's grouped under myocardial infarction. If I click, right mouse click and say go to browser, here we are in cardiac disorders. And if I open this PT now, I have all the different LLTs that are available, and among those, several of them are non-current, and among those also the ambiguous abbreviation MI, because it could relate not only to myocardial infarction, this abbreviation, but it could also refer to mitral insufficiency, mental illness, mesenteric ischemia, etc. And it must not even affect the patient, so not describe a condition in the patient, because MI could also be an abbreviation for medical inspection, so a physical exam. So that is why, let me switch back. We would code this to LLT unavailable event if no further information can be obtained. So most of you went for the unavailable event then at the end, so well done. So that is why you always have to check in the browser, check the hierarchy, check whether a certain abbreviation is available in MedDRA, whether it's current or non-current. And if it's non-current, it clearly indicates that on a global level, this abbreviation is not used consistently and it's ambiguous. So let's stop again, see if you have further questions that you might like to ask. Are there questions, Leander?
Yes, there are questions. So if multiple LLTs are selected to code one event, is it usually possible to keep the link between these codes during the data analysis?
Yeah, that's always a question. It really depends on your database. That's why I do not have one answer for this. This is always a difficult topic. Some pharmacovigilance databases provide this option, that you can link some diagnosis or some clinical signs together and under a certain given diagnosis, for instance. But in clinical databases, often this makes it difficult. You can only analyze the data based on the time of onset, for instance, in order to see what really relates to one another. but that's the only option that you have. So it depends on the database. There's no final answer for that. Sorry.
Thanks, Caroline. For the example of the serum level, if the result is low, why would we choose abnormal instead of low? Is it because they do not specify if low or high?
It's you saw in this example that the diagnosis was hyperkalemia, so a diagnosis that represents an increased potassium level, and that's why it was an ambiguous verbatim. It was conflicting information that we had there, and that's why we were advised to just code to the abnormal lab value. That's the approach that the PTC document provides, and it makes sense.
Thanks, Caroline. And if a term reported is with a spelling typo, but the coder could guess what the corresponding LLT is, could the coder directly code it, or must they query the site? Is
Oof,
there any
that
guidance in that area? That's quite a
Yeah,
challenge.
that really depends on your data entry conventions and again on your database. Usually, if you have this is not a decision of the coder, but of the data manager, and the data manager has to decide based on a data entry convention. So in some instances, you must have go back to the reporter in order to make sure, even if you think that this only always means the same, this must not be the case. So that's why one has to be very cautious in this regard.
Thanks, Caroline. And we've had a couple of people ask for the links to the browser, so I'll put that into the chat so
Okay.
you can have access to the new web-based browser. And I'll also put the credentials in because people are asking for
Okay.
access. So I'll do that now. Thank you.
Mhm. Thank you. So, next topic. When coding investigational results, please remember the following. MedDRA includes medical conditions in the relevant system organ classes, plus related investigational results like lab results in SOC investigations. So you see it here. We have hypoglycemia that is grouped in SOC metabolism and nutrition disorders. And we also have a related um, lab value, decreased glucose. So where you have exact match in MedDRA. And this one at the LLT glucose decreased is grouped in SOC investigations. So for many diagnoses, we have the respective um, lab values or investigations in SOC investigations. Therefore, it is really important to make this distinction. It is a fundamental rule in MedDRA that you should not change internally. Remember, the basic MedDRA coding rule is code as reported. So meaning that if a medical condition is reported, a diagnosis code as such. And when an investigational result like a lab value is reported, select a term from SOC investigations. Never interpret a lab test result as a diagnosis. So that's again a basic fundamental MedDRA rule. I know that in legacy terminologies like WHOART, COSTART, HEARTS, etc., this was not the case. Often we coded lab values to the respective diagnosis because there were not sufficient, there was not the specificity that we have in MedDRA. So MedDRA has the lab values and SOC investigations and the related diagnosis in the respective SOC for clinical conditions diagnosis. So always make this distinction. When receiving precise reports on investigational results, like in the first example here, there are no problems. The value is clearly below the reference range and the verbatim can be coded to LLT glucose low. But often investigational results are reported without units, like in the second example. We do not know whether this year his glucose was 40 refers to 40 milligrams per deciliter, which would be low, or 40 millimoles per liter, which would be high. So such reports are ambiguous and should be coded to a suitable abnormal LLT if there is no option for further clarification. In order to classify lab values as low or high, not just decreased or increased, you will need standard references, I mentioned that before, to decide whether the reported value is clearly below or above the normal range. Quite frequently, a diagnosis is reported with the corresponding values. So if the lab values clearly support the given diagnosis, you are of course not obliged to capture both the diagnosis plus the investigational results. So if these two are consistent, it's sufficient to just capture the diagnosis, because splitting would lead to redundant information otherwise. But when would splitting of investigational results become necessary? So let's have a look at the second example here, where 4 different abnormal liver function tests are reported. Remember the fundamental principle MedDRA coding rule: code as reported. Do not omit parts of the reported events. So do not lump the reported findings under one LLT, like liver function tests abnormal, for instance, but split and code each of the specific reported findings separately. Capture all information as specifically as possible. So you would split code and code to alkaline phosphatase increased, SGBT increased, SGOT increased, and LDH increased in this instance. Now, next exercise for you. Testing showed increased serum creatinine and BUN with increased BUN creatinine ratio. What would you do here? Increased serum creatinine, BUN increased, blood urea nitrogen creatinine ratio increased, or would you code to renal function tests NOS abnormal? What would you do? Which LLT would you select here? Or would you split code? Yes, most of you are on the right path here. So as mentioned before, we would not lump this together. We would always code as specifically as possible and capture the full information that is provided in the verbatim. So let me close it here. So well done. We would split code and capture the given information as specifically as we can. And this means splitting in this instance. The correct assignment here is increased serum creatinine, BUN increased, and blood urea nitrogen creatinine ratio increased. So we would capture the full information. We would not lump it together under a more general vague term. Always code as specifically as possible. Now let's have a look at another example. The patient had features of aldosterone excess. Would you code to aldosterone increased, aldosteronism, or blood aldosterone abnormal? How would you capture the information of this verbatim now? Is this a lab result? Is it a condition in the patient? What happened here? Patient had features of aldosterone excess. Let's see what you're going. Split of opinions. So let me close the poll. So we really have a split of opinions here. So let's look at this verbatim again. Here No investigational result is reported. We are not told that the aldosterone was measured and resulted to be excessive, but it is reported that the patient had signs and symptoms, so features of an aldosterone excess. It is a condition in the patient. And that is why we would select aldosteronism that is grouped under PT hyperaldosteronism that perfectly captures the medical condition in the patient. What is provided here is not an investigational result, but it is a condition in the patient, a diagnosis, aldosteronism. Any questions, Leander?
We've just had one about patient died. Do you want to take that now or slightly
No,
later?
later on, because we have an example
Got
for it.
that one.
Yeah.
Yeah, exactly.
Mhm.
Thank you. Thanks, Caroline.
Thank you. So here comes the next advanced coding principle, combination terms. The first example on this slide refers to such a term, but not to a diagnosis with signs and symptoms, as we saw earlier, but to terms that relate to the same overarching medical concept, but where one is more specific than the other. And this slide shows two examples from the PTC document again. Arrhythmia due to atrial fibrillation. Atrial fibrillation is the more specific type of arrhythmia, so we would code this verbatim to atrial fibrillation because atrial fibrillation is an arrhythmia. Next, the other one is hepatic function disorder specified as acute hepatitis. Again, we code to the specific type of hepatic function disorder, the acute hepatitis in this instance. Sometimes you'll see MedDRA combination terms which relate to two separate medical concepts, for instance, combining a defined medical condition with its etiology or additional attributes. Remember our previous example with the sepsis and the shock where we found a combination term, septic shock. And here we have additional examples. Retinopathy due to diabetes can be coded to one LLT, capturing the full information, diabetic retinopathy. Rash with itching can be captured with one LLT, itchy rash. And breast cancer HER2 positive can be captured with HER2 positive breast cancer. So HER2 stands for human epidermal growth factor receptor 2 and is an overexpression that promotes the growth of cancer cells. So meaning that its presence has a significant impact on treatment decisions and also on the prognosis of the patients. And it needs to be captured when reported. So again here, perfect combination term is available in MedDRA. If you get a verbatim representing combination of relevant clinical information and no corresponding combination term is available in MedDRA, then you should split code. You should select more than one LLT to capture the full relevant medical information. In the first example, we would split into diarrhea and vomiting. We wouldn't lump this information under more vague LLT like gastrointestinal upset, for instance. Remember, always code as specifically as possible. In the next example, a wrist fracture due to a fall is reported. Again, capture all information. The fall may have been caused by the drug because it made the patient feel dizzy, for instance. So you have to capture all information to be able to search for it in your database, to be able to look for patterns and safety signals. And then we have a reported BRAF positive malignant melanoma. Again, split this information to capture both the specific malignancy, the malignant melanoma, but also the gene mutation because it is relevant for therapy decisions and also for the prognosis of the patient. Now it's your turn again. Here, a retinal disease from HIV with near total blindness, right and left, is reported. So, how would you code this one? Retinal disorder, HIV disease, blindness, HIV, retinopathy, or blindness both eyes. How would you capture the full information of this verbatim? Let's again look what you're going for. Yes, exactly. So HIV retinopathy is a perfect combination term for the retinal disease from HIV. And you would, of course, not only code blindness, because we know that it was a near total blindness of both eyes. So we would also select blindness both eyes in this instance here. So when you look for when you get such combination terms in your verbatims, always look out for such combination terms in MedDRA, because MedDRA contains quite a number of such combination terms. Look out for them and use them. So here we are. We would code to HIV, retinopathy, and blindness, both eyes. The next advanced topic are medication errors. A medication error is any unintentional and preventable event that may result in the improper use of medication or harm to the patient while the medication is under the control of those involved in the medication use process, meaning physicians, pharmacists, nurses, patients, consumers, or their family members. The second aspect that is highlighted in green here is important to remember. These errors occur during product use in the medication use process, when the product is under the control of the healthcare provider, patient, or consumer. The term does not refer to errors that occur during manufacturing or are caused by wholesalers. In other words, outside of the control of the healthcare provider, patient, or consumer. If a medication error is reported with clinical consequences, like in the first example, patient was administered wrong drug and experienced hypertension, both the medication error and of course also the consequence of the error needs to be captured. Here, the fact that a wrong drug was administered and the resulting event in the patient, the hypotension. In the second example, it is reported that because of similar sounding drug names, the wrong drug was dispensed. As a result, the patient took the wrong drug and experienced a rash. We have 4 interrelated events here. First, the wrong drug was dispensed. And the report also states that there was a contributing factor to this, contributing to this error, that the 2 drug names sounded alike. The consequent error is the administration of the wrong drug. So it was not only the wrong drug that was dispensed, but it was also administered, so it reached the patient. This also needs to be captured. And it led to a rash in the patient. Again, it's a chain of events and all reported events have to be captured. Wrong drug dispensed, wrong drug administered, drug name sound alike, and rash would be the correct code assignments here. And in the third example, it is reported that insulin was given using the wrong syringe. Here we have 3 interrelated events. Because the use of the wrong syringe resulted in the administration of an overdose, and the patient then developed hypoglycemia. The medication error is the administration of the drug in a wrong device. Drug administered in wrong device would be the LRT that needs to be selected. It resulted in an overdose, and because this was an accidental administration of this overdose, we can code it to accidental overdose. It was not intentional, but can be specified and coded as accidental overdose. And the result is the hypoglycemia. And you have the 3 LLTs here. If a medication error is reported, it is made clear that there were no clinical consequences. The PTC guidance provides us with 2 coding options. When it is reported that an intramuscular formulation medication was given intravenously instead of intramuscularly, but the patient did not experience any adverse effects, it would be sufficient to just select LLT intramuscular formulation administered by other route. But you could also take the alternative approach and code no adverse effect in addition. Again, a preferred and an alternate option here. We have this quite often when it comes to no adverse effect, and it's your decision how to approach such coding scenarios. But again, document your decision in your in-house coding conventions and apply them consistently. Sometimes potential medication errors are reported. Such incidents should also be captured as specifically as possible. Also, the contributing factors should be captured, like in this example from the PTC document, where it is reported that a pharmacist notices that the names of 2 drugs look similar and is concerned that this may result in someone getting a wrong drug. So here we would select drug name lookalike to capture the contributing factor, and we would also capture the potential for a medication error with a very specific term, potential for medication error, wrong drug. Why do some regulators want to receive this information, are actually very keen to receive such information? Well, in such scenarios, no medication error happened yet, but could of course occur in the near future based on the reported contributing factor, the drug name lookalike. When understanding the background for these potential errors, regulators can take steps to prevent errors even before happening. So depending on your local requirements, do not omit such information, but capture all relevant information when receiving similar verbatims and code both the potential for an error by selecting one of these LLTs that are available, and also code the contributing factor or factors. So although not being an adverse event, such incidents may need to be included in periodic safety reports as well. So this really depends on your local regulatory requirements. Any questions, Leander, for this topic here?
Yes, we do, Caroline. Sometimes it's difficult to know whether it's a medication error or use. Whether it's a medication error or use intentionally outside of the MA. So what should we assume? It's a medication error?
No, we have many terms in MedDRA that end with issue. So these are the more general terms that you can use if it's not made clear whether something occurred accidentally or intentionally. Then you can assume that it's an issue. And we have many LLTs that do not contain the information accidental or intentional. So look out for them. They're really very specific terms for all these deviations from the label. And I can only recommend to also attend the webinar for medication errors that we provide, because it's a quite complex topic, this whole medication error, misuse, off-label use, etc., how to classify these incidents. And I will not be able to really cover all the details in this webinar here.
Thanks, Caroline. And then we've got one about splitting verbatim. So is it preferred to ask for splitting a verbatim or to assign several LLTs to the initial verbatim?
So it depends on your verbatim. If you can, you should always code as specifically as possible. So if you have a verbatim that relates to many several different medical conditions or several different investigational findings, you will have to split code. If you find a combination term where you have, let's say, you have a medical condition and demographic information, or a medical condition and etiology reported in addition, or you have the information that it is a procedural complication, then look out for a combination term first, before splitting a term. So always try to find a combination term, but do not omit information, as I've shown with the investigational terms that related to hepatic lab values, where we have very specific ones for the different lab values that can be reported for hepatic disorders. You should always code as specifically as possible and not just lump them under hepatic, I don't know, lab results abnormal or cardiac results abnormal.
Thanks, Caroline. We're getting quite a few on medication errors, but I think probably in the interest of time,
it's
we'll
much.
need to
I
move
can.
on.
You see here we have learned more about medication errors. First of all, we have the MedDRA term selection points to consider. There is one section for medication errors, accidental exposures and occupational exposures you can refer to. We also have the so-called companion document in section 3. We have a whole section, more than 50 pages, about medication errors that really provides detailed coding examples, and also has a question and answer section on medication errors. You should become familiar with the categories and terms under this HLG team: medication errors and other product use errors and issues, in the MedDRA browser, and review also the relevant terms in the MedDRA concept descriptions. And here are the MedDRA training resources that we have on medication errors. First of all, our webinar, MedDRA Coding of Medication Errors, General Principles. The next one will be provided in June in English. There is also one in Spanish that will be providing beginning of June. Then we have our learning management system module about special situations that also includes the medication errors. So that's for self-learning, our self-learning module, and also recorded videos of our, for instance, coding of medication errors webinar. And I'll show you later at the end of the webinar where to find this YouTube channel and the recorded sessions. Also a demonstration of the new web-based browser. I cannot take all these questions today because I have to rush up a little bit in order to really come to the exercises as well. So next topic that may also relate to medication errors is overdose, toxicity, and poisoning that is addressed in the MTS Points to Consider document. If overdose, poisoning, or toxicity is reported, extract this information and code accordingly. Poisoning by drugs and drug toxicity are considered synonyms in MedDRA. You will find the relevant terms under the PT toxicity to various agents. You may ask yourself when to consider a high dose as overdose. So, well, there is a concept description in the browser. It says, for the purposes of term selection and analysis of MedDRA-coded data, overdose is more than the maximum recommended dose, either in quantity and or concentration. In other words, an excessive dose. And if an overdose is reported with clinical consequences, you would code both the overdose and, of course, also the resulting events. And if there are no clinical consequences, again, you have two options. The preferred one, provided in the Points to Consider document, asks to code the overdose only, but you also have the option to select the alternative approach and also code no adverse effect. We had this question before about fatal outcomes. So One advanced principle addresses death and other patient outcomes. Death, disability, and hospitalization represent patient outcomes and are normally not captured as adverse events or adverse reactions. But if one of these outcomes is the only information received, then you would code as specifically as possible. And also, if a death term would add relevant medical information, you would code it in addition. Here an example. If it is reported that the patient experienced a rash and had sudden cardiac death, you would code, of course, the rash, but also the sudden cardiac death. You would not ignore the information sudden cardiac death and not capture it. You would, of course, omit relevant clinical information otherwise, because it can be considered unusual that a rash leads to sudden cardiac death unless the patient had additional medical problems. Suicide and self-harm is another topic addressed in the points to consider guidance. When coding suicide attempts, completed suicides, and self-harm, clearly distinguish these scenarios. Be as accurate as possible and handle these terms consistently. Do not assume that an overdose, even if it is reported as intentional, relates to a suicide attempt. Same holds true for reports on self-injuries. If a suicide attempt or suicide are not mentioned in the report, only code the intentional overdose or self-injury. Remember, again, the basic coding principle: do not interpret what has been reported by adding information, code as reported. And if a suicide attempt has a fatal outcome, make sure to capture it as a completed suicide. The outcome makes a big difference here and needs to be considered when coding. And this was actually what an inspector checked in a drug safety database of a pharmaceutical company. He asked for all cases that were coded to LLT suicide attempt, but with fatal outcome, in order to assess the quality of data entry and coding in this database. So really important to make this distinction. So based on what you just heard, which of these LLTs would one select for a reported death from cerebral hemorrhage? The verbatim specifies an event with its outcome. So death from cerebral hemorrhage. Options would be sudden death, cerebral hemorrhage, or brain death. And as just discussed, in such cases, we do not need to code the death of the patient because it is an outcome and captured in a separate data field as a seriousness criterion. In our case, the reason for death is reported, and this is what we should capture. And LLT brain death means something different. It means that the brain has lost its function, but the patient must not be dead, but maybe comatose and depend on life-sustaining measures. And that's why we would code to cerebral hemorrhage in this instance. But if the outcome death is the only information in a case, then of course an appropriate LLT for the reported circumstances of the death of the patient must be captured. So for the reported outcome, patient was found dead, LLT found dead would be the most suitable term assignment, as it is closest to what has been reported. Death would be too vague, and when assigning death from natural causes or died in sleep, we would add information that was not reported. So in this case here, the appropriate fatal outcome LLT has to be coded to found dead. This was the only information in the verbatim. So any questions related to this last section, Leander?
Not on this one at the moment, Carol-Ann. We've got some from earlier that I'll cover at the end with you.
Okay. So the last one, before we start with the exercises, is the principle how to code drug interaction. The term drug interaction covers interaction between drugs, including biological products, but also between drugs and foods, drugs and devices, drugs and alcohol, etc., etc. If an interaction is reported, then capture the interaction and the subsequent medical events. And here's an example. Patient drank cranberry juice, which interacted with anticoagulant drug, causing an INR increase. It is clearly stated by the reporter that an interaction occurred, and we should capture this information. Make sure to code the interaction as specifically as possible. Here it is a food interaction, but you may also receive reports of drug-drug interactions, drug-alcohol interaction, device interactions, drug-device interactions, drug-disease interactions, herbal interactions, or radiation interactions, and always code as specifically as possible, because all these concepts are available in MedDRA. So here we have a food interaction with subsequent consequent of this interaction, that is the INR increased. But what if a reporter does not specifically state that an interaction occurred, but only mentions that 2 or more drugs were taken together and reports a medical event afterwards? So in such instances, you should not assume an interaction just because the patient has taken several drugs, but select terms for the reported medical events only. Very important. Again, do not interpret, only capture an interaction when it is definitely reported. Do not assume that an interaction occurred. Another one for you. After taking an antihistamine along with her prescribed proton pump inhibitor, a 53-year-old woman developed vertigo. Which LLT or LLTs would you select here? Drug interaction in NOS, vertigo subjective, vertigo, or drug interaction? So think back about what we have just discussed regarding interaction. Let's see what you're going for. Vertigo is the preferred approach. Well done. Yes. Let me close the poll. We are not told that an interaction occurred in this instance. We should not assume it. The only thing that we know is that the patient took 2 drugs concurrently. We should not assume an interaction, but code as reported. The correct code assignment would be LLT vertigo, and most of you have proposed this LLT assignment. Well done. It was not just a feeling of vertigo, it was really a vertigo that the patient suffered. So vertigo subjective was incorrect as well. And we are often asked when to use NOS terms and when not. It doesn't really matter, but good practice is to only select NOS LLTs when it is clearly stated in the verbatim that the condition cannot be further specified. NOS, you know, stands for not otherwise specified. So now we come to the coding exercises, unless we have questions that relate to the last principles. Leander.
We do have a couple of questions on interaction. So if an interaction is not mentioned by the reporter, but an interaction with these drugs is captured in the SMPC, should this situation be encoded?
Oh, this is a very specific question. This depends on, I know this from my previous work, depends on your data entry conventions. In principle, you should not assume anything, but if you have data entry conventions for your pharmacovigilance database for specific products where it's fully clear that this is definitely an interaction, then you may want to document this in the data entry conventions and then code it accordingly. But this is it's very specific for the product and also for the respective company.
Thanks, Caroline. And what is recommended? What is the recommended approach when an adverse event is suspected to be due to a drug interaction, but the reporter only lists one drug?
If we only have one drug, how can you assume an interaction? So I would, as I said, do not assume anything. This is really not the purpose of coding. Especially in pharmacovigilance, you have to differentiate between data entry tasks and coding tasks. So if you are a coder and then you code what has been extracted from the case narrative, and this is what you should code. So if there's no interaction reported, if there's no, then you cannot code to an interaction unless data entry conventions really allow for certain to code to certain interaction terms, but then this needs to be extracted accordingly so that it's fully transparent that the coder assigned the correct code here. You cannot just have the two drugs were taken together with the specification of the drug and then code this to interaction. That would be definitely incorrect. Then the term extraction by data entry needs to be correct and really precisely follow the data entry conventions and include the information about interactions in the term to be coded.
Thanks, Caroline. That's it for that particular part. Like I say, I've got a couple of questions from earlier, but I'll hold those to the end.
Mm-hmm. So we will now move and work on some more exercises. So we may not be able to cover all of them because of time constraints, but I wouldn't like to rush through these exercises, so that in my view, that would not be a good condition for understanding the different coding scenarios and also for learning how to handle them. So let's see how far we get. And I really have to say that it's difficult to find the right balance between the number of exercises and the time spent on them, because in the feedback we receive after our training sessions, some participants would like to see fewer examples with more time for discussion and explanations, while others would like to see more examples and not spend too much time on individual verbatims. And these expectations are really hard to bring together, so I will try my best in this instance. As already mentioned at the last Coding Basics webinar, before searching in your browser, it is always good practice to check what exactly has been reported. First, look at your reported term, the verbatim. Is it a clinical condition, a diagnosis, a sign or symptom, indication for use, a test result, injury term? Is it a procedure that was reported or a medication error, a product use issue, etc., etc.? Or is it a combination of these? And these may have to be split, because the type of reported term will influence where you would look in the browser to find the closest LLT or LLTs that best match your verbatim. If it is a medication error, you would look into this injury SOC. If it is a product quality issue that is reported, you would search in product issues SOC, etc. So now let's start with our exercises, and you can test yourself in applying the advanced principles we have just discussed. You have this already in, Leander has provided you with these credentials already. So here they are, and they are exactly the same for the legacy browser as well as for the new browser. So you may select the one that you want to use. If you would like to use the new one, then look for how to use, click on it, select tools, and then this window will open. And here is the link to the new web-based browser. And here the one to the legacy browser. Here's the shortcut on the MedDRA website. And here again the QR code, just in case you have lost connection to the paw. And here's our first one. Became colorblind in adolescence. How would you code this? Color blindness, blindness color blindness acquired, or color blindness acquired in American English. What would you do? Which LLT would you select? Became colorblind in adolescence. Most of you are going for color blindness acquired in British English, others color blindness acquired in American English, but others would also consider to go to color blindness or blindness color. Let me close it. So the key thing here is really that color blindness is normally a congenital disorder, and that is why it is placed under the congenital SOC in MedDRA. But here we are told that the patient became colorblind in adolescence. So we will have to look for a term which includes the information that the condition was acquired. So let me show you again in the browser and look for color and blind. And here we have color blindness. Right mouse click, go to browser. And you already see that color blindness is grouped in the primary SOC congenital. It's considered a congenital disorder. And here we know that the patient only became colorblind in adolescence. So we will have to look for a different term. And here it is, color blindness acquired. Again, in American English, go to browser again, right mouse click. And here we have the acquired color blindness. You see it's grouped in eye disorders, not anymore in the congenital SOC, of course. And this term here really covers what has been reported. Color, we see both the British English spelling, American spelling, and on PT level, you always only find British spelling, the terms in British spelling. So let me go back to my slides. So because, again, a nice example why checking the hierarchy is always important. So here we would code to color blindness acquired because it's reported in or written in American English. We would keep as close to the wording of the verbatim as possible. So it doesn't make a big difference, but it's good practice to always follow not only the actual wording of the verbatim, but also whether it is spelled in British or American English. So match the spelling of the verbatim to American or British English at the LLT level. And on the PT level, you will always find British English based on MedDRA naming conventions. So this is the correct LLT here. Color blindness acquired reflects both the acquired nature of the condition and also the appropriate spelling based upon available American and British spelling options. Questions, Leander? Are there questions?
No questions on that topic. Thanks, Caroline, that question.
Mm-hmm. Next one. Turned very greasy. What would you select here? Ill-defined disorder? Is it a condition in the patient? Unavailable event? Skin greasy? Or unavailable reaction? What would you select? Turned very greasy. What could this relate to? Remember what we discussed before about ambiguous verbatims and vaguely reported events. So if you cannot get more information, of course you would ask for more information if you can, but in many instances, especially in pharmacovigilance, you don't find or get more information. So what can we do then? Which of these LLTs would you assign? Unavailable event is a preferred option. Let me close the poll. Of course, you can ask yourself, is the skin greasy or the hair greasy? Turning greasy may not even affect the patient, but may relate to a medicinal product like an ointment, which has become very greasy. So that is why I wouldn't go for ill-defined disorder or even skin greasy, because it would be an interpretation. It would be an assumption that the skin of the patient turned greasy. We also don't know whether this was a product quality finding or whether it really affected the patient. So unavailable reaction would not fit either. We do not know whether the verbatim describes a reaction to a medicinal product in the patient. In this instance, the best LLT to select here is LLT unavailable event again. So always think about, is it in a condition in the patient? It is clear. Is it clear that it is a condition in the patient? Could it be something else? And if you cannot clarify, then whether this is a product quality issue or a condition in the patient, then because reaction would be a condition in the patient as well, then select unavailable event. Here we are. Patient reported a medical problem. Now it's quite easy. What would you do with this one? Adverse event, unavailable reaction, or ill-defined disorder. Let's see. Yes, you're going right. So it is a condition in the patient that is clear. We don't know whether it's a reaction to a drug or a medicinal product. Unavailable event would be too vague in this instance because we know it's a condition in the patient. And the best approach, also recommended by the PTC document in this instance, is to select LLT, ill-defined disorder. Here we are. So we had a similar example before when discussing all the advanced principles from the PTC document. Here one that relates to diagnosis with signs and symptoms. We discussed before this principle. The patient reported a loss of smell and thought that he might have a COVID-19 infection. So he might have a COVID-19 infection, if this is a confirmed diagnosis or a provisional one. And then we have a clinical sign, a loss of smell, symptom in this instance. Anosmia, suspected COVID-19, loss of smell, or COVID-19. What would be your preference regarding code assignments? Suspected COVID-19, correct. He might have COVID-19. It's a suspect diagnosis. And anosmia is, of course, the medical term for loss of smell, but we always try to select the LLT that is closest to the wording of our verbatim here. A loss of smell is reported. So we would code to suspected COVID-19 and loss of smell, and would to capture the full information of this verbatim based on the guidance that we saw before for the suspect diagnosis, where we are asked to code not only the suspect diagnosis, but also the clinical signs and symptoms in all instances. Here we are. Next one. He was given drug Y to treat BRAF gene mutation-related colorectal cancer. So how would you approach this verbatim? Would you select colorectal cancer, acquired gene mutation, BRAF gene mutation, colorectal carcinoma? What would you do? Would you split code? So always try to keep as close to the verbatim as possible. Colorectal cancer is the underlying disease. And then we have additional information about a gene mutation. We discussed this earlier as well. This needs to be captured because it's important information that is relevant for treatment decisions and also for the prognosis of the patient, also in this instance. So most of you got it right here. Colorectal cancer, this was reported. Always keep as close to the verbatim as possible here. Colorectal carcinoma is grouped under the same PT, but we always try to really have the verbatim as a guidance for term selection. And BRAF gene mutation, of course, needs to be captured as well. Here we are. Infection after surgery. How would you approach this verbatim? Would you go to infection, post-operative wound infection, surgical wound infection, or post-operative infection? Which LLT would you select? Yes, you're fully correct. Post-operative infection would be the correct assignment here. We have many post-operative terms in MedDRA. Always look for them. Here we are, post-operative infection. This term reflects the nature of the event, the infection, along with the temporal occurrence, temporal association with the surgery. So a perfect combination term in this instance as well. She was abused by her husband. Which LLT would you select here? Physical abuse, battered wife, spousal abuse, or victim of spousal abuse? You see the granularity of MedDRA again, how important it is to really look at the verbatim in order to make your coding decision. She was abused by her husband. Perfect. Spousal abuse, I will show you in a minute in the browser. Most of you went for victim of spousal abuse, and this is fully correct. So physical abuse, we don't know whether it was a physical abuse, so we cannot assign physical abuse or battered wife. The verbatim may also relate to verbal, sexual, or psychological abuse. So here we are. So let me switch to the browser. Oops, not correct. Here we are. And I will do a bottom-up, top-down search, collapse all. We will have to go to social circumstances in this instance and to legal issues. And here we have two HLTs, crime victims and criminal activity. Under criminal activity, you will find some terms like here, so they describe activities of the abuser, like for instance here, physical abuse. Yeah, this was one option. Physical assault, sexual abuse, spousal abuse as well. Here it is. But this is the abuser. In our instance, we had a crime victim. And here we have a victim of abuse, sexual abuse, and here is the victim of spousal abuse. We have the battered wife here, but we don't know whether it was a physical abuse. So victim of spousal abuse would be the best approximation to what is reported in our verbatim. Here we are, victim of spousal abuse. Next one, The patient was treated with drug Z for rosacea, which is an off-label use of this medication. Unfortunately, she developed severe dizziness. So the patient was treated for rosacea. This indication was not covered by the local label. It's off-label. And then developed severe dizziness. Which LLT would you select? Or LLTs in this instance? Rosacea, off-label use in unapproved indication, off-label use, and or dizziness. Yes, we would code the rosacea. That's the indication for use. Off-label use is only reported in pharmacovigilance, of course. So here we will have to code the indication for use, rosacea. Off-label use in unapproved indication is the most specific term that we can select to describe the off-label use, because it could also be an off-label dosing or whatsoever. And then, of course, we also have to capture the adverse event in the patient, so the dizziness. Here we are, and most of you got it right. We would code the indication for use, rosacea. We would assign the most specific term that we can find for the off-label use, that is off-label use in unapproved indication. And we would, of course, also capture the dizziness that the patient suffered after the off-label administration of the drug. Next, a 27-year-old woman took the 2-week course of antibiotics during her pregnancy. She did not experience any side effects. What would you select? Which LRT would you select here? Maternal exposure during pregnancy, no adverse effect, and or normal pregnancy. Yes, maternal exposure during pregnancy is of course to be captured. We don't know in which trimester it occurred, so we cannot code more specifically. No adverse effect, that really depends on your coding conventions. We always take the preferred approach, and the preferred approach always says to not capture the no adverse effect information. But you may, of course, also take the alternative approach. We discussed this before. Nobody has voted for normal pregnancy. That's very good, because this would be an interpretation. We don't know whether there was a normal pregnancy. We only know that this administration of the antibiotics did not create any side effects. But the pregnancy may not have been normal, may have had premature contractions whatsoever. So, well done. So here you have again the guidance in the MedDRA points to consider document. Again, the preferred approach would be to only capture the maternal exposure during pregnancy, but you may also, of course, take the alternate approach and code the no adverse effect in addition. Because we always use the preferred approach, here our recommendation would be to code to maternal exposure during pregnancy. Just to let you know, these are all the terms that are available in MedDRA currently for capturing exposures in pregnancy, delivery, and lactation. The first three, here you see that the first and the third one, these are quite general and vague, and they do not specify whether the mother or father or fetus was exposed. And the second here, the second PT, refers to a fetal exposure due to a maternal infection. The next 5 PTs relate to fetal exposure via breast milk, during delivery, during pregnancy, timing unspecified, or via father. The next ones, the 6 next ones, relate to exposure of the mother during pregnancy, And the last 3 to the exposure of the father during pregnancy of the partner. So make sure to really get familiar with all these PTs and clearly distinguish them when coding respective or similar cases. So it's really important to precisely distinguish between these very specific terms. Another one, we are approaching the end of this webinar now, so let's try to cover 1 or 2 more. The 2-year-old accidentally took his mother's medication. Which LLT would you select for this verbatim here? Accidental overdose, accidental exposure to product by child, accidental drug intake by child, or unintended ingestion of product by child? Remember, always try to code as specifically as possible based on the verbatim information. Accidental drug intake by child, exactly. We know it's a medication, so it's a drug. We have demographic information, it was a child, and it was an accidental exposure. Accidental exposure to product by child, this could be also a device or something else. We know it was a medication, so accidental drug intake by child is the most specific term that we can find. We don't know whether it was an overdose, must not have been an overdose. And unintended ingestion of product by child, again, here we have the ingestion, but it's only a product that is mentioned here, not a medication. So this one here, accidental drug intake by child, really perfectly captures what has been reported in this instance. Here we are. And let me shortly again show you in the browser. And here, let me collapse everything and go to SOC injury and take the top-down approach here. Here we have the HLGT medication errors and other product use errors and issues. And if I open it, you see that on the top we have the accidental exposures to product. And you see that we have an accidental device ingestion, but also an accidental device ingestion by child, or an accidental exposure to product, but also an accidental exposure to product by child or by an elderly person. So here demographic information is represented on PT level. And also we have an accidental exposure to product packaging by child, because often an accidental ingestion of product desiccant is reported. So here we have very specific terms. Here we have accidental exposure to product by child, and here the one that we saw, accidental drug intake by child. That would be the correct code assignment here. And underneath you find all the terms that relate to medication errors and other product use issues, grouped by the stage where the errors or issues occurred. And more of that, as I said, in the webinar for medication errors. So I will now go to the, hopefully it works. Doesn't work. I would like to skip this and go really to the end. Here we are. So at the end of our session, in order to not overrun the time here, let me now provide you with a summary of some relevant coding tips and hints, what we call the coding pearls. First, I would like to emphasize that MedDRA can not only be used for adverse event coding, but also for coding of indications for use, medical history data, risk factors, investigations, medical procedures, etc., as we saw today. The slide gives you an example of a case information in a narrative format that those of you working in pharmacovigilance are probably very familiar with. So we are provided with information of the indication for use of a drug, that is rheumatoid arthritis, that is taken By a 75-year-old male, we get information about his medical history, colon cancer, and risk factors like cigarette smoking, the development of an AE, that is the aortic valve stenosis, a surgical procedure to treat the condition, the aortic valve replacement, and a subsequent post-operative complication, so the sternal wound infection. And all information highlighted in red lettering can be captured with MedDRA. Whenever you are searching for a suitable term for a verbatim or for terms from narratives like we saw before, first try using the actual wording of the reporter. You better use word stems, like for example pancreas, to cover both pancreas and pancreatic for your search, because if you are too specific in your search, you may not find any results. So use word stems wherever possible. And you should use singular terms, not plural terms, because MedDRA is a singular terminology. And replace words with synonyms if you don't find a suitable hit in MedDRA, like for example, replace intentional by deliberate or unintentional by accidental when coding errors in medicinal product use, or replace hand by arm, for instance, when having a condition in the hands only, or extremity. If you have found a somewhat suitable term, be aware of MedDRA specificity and always look for LLTs under the same PT that may even better capture the verbatim, and also look for sibling PTs in the same grouping, in the same HLT, because there may be PTs that are better matches to your verbatim that include additional information, like for example, demographic information, the information acute or chronic, post-procedural occurrence, etc. And remember the example where we looked at the verbatim reporting a drug exposure by child, where we saw that there is a PT for accidental product exposure, but also a separate PT for accidental product exposure by child. And if you have found a suitable term, always check the hierarchy, where the term lies in MedDRA, in order to reassure yourself that the hierarchy represents your reported condition correctly. Remember our example with the acquired color blindness. If we had chosen just color blindness, it would have been in the congenital SOC, and that hierarchy would be wrong for our coding scenario because the verbatim was referring to an acquired condition. When searching for suitable terms, use the top-down and bottom-up navigation. If you have difficult verbatims, use available resources for clarification, among those also the concept descriptions that you can find in the MedDRA browsers. And you can also use the advanced search function or restrict your search to a SOC to narrow down your searches in the browser where necessary. And of course, you should get more coding training and of course, coding practice via high coding turnover. The more you code, the more experience, the more professional you will get, the more accurate and consistent your coding output will be. So this is what we have covered today. And now is your last chance for questions.
Yes, we have a few, Caroline. So on the child accidental intake, do we know that taking is the same as intake? Might it be ointment as well?
No, I think an intake is an ingestion. I think it's really clear from the verbatim. I think would not be an interpretation, but it would be legitimate to consider this an ingestion. You're a native speaker, Leander.
Yes, I agree. I think so, but I do get where the person's coming from.
Yeah.
So in the dizziness example,
Yep.
in this case, why do we have to capture the indication?
Well, it really depends. Usually you would in the dizziness. I think we had the dizziness with the interaction, wasn't it?
Yes.
I don't recall. Um, so the indication for use is captured in pharmacovigilance. This, of course, does not apply to clinical trials. But if you have an off-label use in an unapproved indication, in this instance, it this was the case, and then the patient experiences dizziness, you would code the off-label use as specifically as possible, and then code the dizziness in addition, because this off-label use caused an adverse reaction in the patient, and that's why we would need to cover all information that was contained in the verbatim, including the indication, because it's relevant to know what type of indication was what was the indication that this drug was used off-label for. You would always try to capture the full information.
Thanks, Caroline. And one more relating to those particular examples. The maternal exposure during pregnancy example, what about
Mhm.
intentional versus accidental exposure? Does that matter?
I think it doesn't matter in this instance. So, of course, if you have a drug abuse or so, you would capture it elsewhere. But when you only look at the exposure of the fetus, or then it doesn't matter. It's additional information that needs to be coded then. But when only focusing on the drug exposure during pregnancy, then these are the allied or the PTs that are to select, the ones that I've shown. But if you have a drug abuse, of course, then it's also a different story. There are separate PTs for such scenarios that you can choose from.
Thanks, Caroline. And then what is the significance of coding indication of off-label use as an event?
Well, this is again in many countries it's a regulatory requirement to report off-label use. It's very popular in oncology, for instance. And of course, regulators want to know in which direction certain indications drift for given drugs that are not covered by the label. That's why many regulators are really interested in getting this information about off-label use and also specifics of the off-label use, whether it's indication for use or route of administration, or whether it's dosing whatsoever.
Thanks, Caroline. And a question related to earlier was aldosterone increase will also refer to excess. Is that right?
The aldosteronism example, again, you would need to look into the browser whether this it's the aldosterone excess was a condition in the patient. The patient had signs and symptoms of aldosterone excess. So it was a condition in the patient. And what this example wanted to demonstrate is that uh, you would try to find a term that really represents a condition in the patient and not an investigational result.
And again, back to slightly earlier was somebody said, can we not club atrial arrhythmia as we have this term available in MedDRA?
Well, atrial arrhythmia would be more vague. It could also not only refer to atrial fibrillation, but also to other atrial arrhythmias.
Thank you.
And what?
And the
Mhm,
person just came back and said aldosterone excess is not available in MedDRA.
mhm. No, when it's not available, then yes, but you would have the option to go to aldosterone increased, for instance, with an investigational term, and this is would be incorrect in this instance because what has been reported in our example was a condition in the patient.
Thanks, Caroline. And one more. We've had what about steroid abuse? There is no steroid misuse term available.
Oh, that's that's too
Must be
specific.
different.
I would need
Yeah,
to
that's what I thought.
I would need to browse myself. I know that there is something in MedDRA, but I cannot tell immediately what term it would be.
And if people have got suggestions for coding terms, they can always add them into your Let's Code, that is quite a popular webinar as well.
Yeah.
I think that's it for now, Carol Ann. In the interest of time, I think we've answered all the ones that we can here.
Okay. So just some additional information, links to useful information also to our MedDRA browsers, link to the training schedule where you can find other webinars, and to the MedDRA support documentation. I wasn't able to show you today, so this is the link where you can find the MedDRA introductory guide, the MedDRA term selection points to consider document for MedDRA term selection, and also for the medication error topic, the companion document. Here is what you can expect to in May and June. So this is the one that we have today, this webinar here. These are the webinars. MedDRA Coding Basics will be provided again on the 5th of June in English and end of June in French. This is the one that we have today. Another one will be provided on the 11th of June and mid of June also in Chinese. The Let's Code Together webinars are also very popular. They are in a workshop format. They are provided really for more advanced coders. So if you're a newcomer, I think you have to wait a bit and get more experience. Otherwise, you will get lost because the examples that we discussed there are more complex. So the next one will be provided in Korean, and the next ones in English will be provided in the second half of the year. And here is the link or the possibility to attend the MedDRA Coding of Medication Errors General Principles webinar here in Spanish, beginning of June, and end of June here in English, Central European Summertime. Now I would like to show you here links to our different chat groups, contact form that you can use in order to contact the MSSO. And you can also follow us on social media. And what I would like to show you now is the YouTube channel. And for that, I will have to switch to, where is it? Where is my, here it is, the MedDRA website. And if you click on contact on the top, you will be brought exactly to the page that I've shown you. If you click on this icon, YouTube, you will be brought to all the recorded sessions, webinars that we have in different languages. And here is my colleague Jane. And here you will find, of course, the demonstration of the new web-based browser if you are interested in it. Here it is. So Jane has provided it. When was it? I think in do you know, Leander? I think in March, April it was.
Yeah, I don't know off the top of my head. I'm sorry.
Yeah. Here are the Let's Code Together webinars, many of them that Jane and I provide. You also have them in Russian. You saw that we are starting to provide them in Korean as well. Our colleague Juni, also Tomas and Ana Garcia Rubio, they provide it in Spanish. It's also provided in Chinese. So we have lots of options here. And also we have the option, we have here myself, and also the medication error webinar here is recorded from last year, and in June the next one will be provided. So just to let you know, if you have difficulties with internet access or when the time zone does not really fit your schedule, you always have the option to watch these recorded webinars. But of course, you cannot raise questions. That's the only disadvantage that you have. And with this, let me go back to my presentation, and I hope that you found this webinar useful, and hope that we meet again in one of our trainings that we offer on a regular basis. Thank you for your interest in today's topic and for your really active participation, for all your questions. And a big thank you also to you, Leander, for your support, for monitoring all these questions today. So enjoy the rest of your day wherever you are, and I hope to meet you again in the future. Goodbye for now. Bye bye.
Thanks, everyone. Bye bye. Bye bye.